Good evening, and thank you for joining us tonight for the medical update in lung cancer and National Lungs Cancer Screening Program, part of Chris O'Brien Lifehouse CPD series. My name is Lydia Koenig. I am a CPD Program Officer at Central and Eastern Sydney PHN. Also working with us tonight, CPD and Events Manager, Bertha Harvey. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continued connection to land, water, and community, and pay respect to elders past, present, and emerging. I'd also like to extend the respect to Aboriginal and Torres Strait Islander peoples joining us tonight. Please note this event is being recorded and placed on our video library in the upcoming days. Please submit your questions to the Q&A function, and chat function is disabled. We'll attend to your questions at the end of the presentations. At the end of this event, our evaluation survey will pop up on your screens. Please take the time to fill them out to allow us to issue your certificates of attendance and to submit your CPD activity hours. All the upcoming events are on our website, available for registrations, including July CPR workshop at Waverley Library, Bondi Junction. And to start with tonight's session, I would like to invite Tammy Shapiro, Reviews Project Officer with HealthPathways Sydney. Thank you, Tammy.
Thank you, Lydia. Good evening, everyone, and thank you so much for having me. Just going to give a quick overview of both the HealthPathways Sydney and Southeastern Sydney programs tonight. I'm sure many of you here with us online are very well familiar with both programs, but just a nice little recap and then give you a hint at what's coming soon in the space of lung cancer screening, which we're very excited about. So for starters, just to be clear that in the Central Eastern Sydney PHN, we're very lucky in the sense that we've actually got two HealthPathways regions. So we've got the Southeastern Sydney region, and that covers our eastern and southeastern aspect. So that's for hospitals such as Prince of Wales, Royal Hospital for Women, St George and Sutherland. And then you've got Sydney HealthPathways, that's the program I'm here representing this evening, and that covers our central Sydney region. So we're thinking RPA, Concord, Canterbury, Balmain, and the sort of inner city region. We're very happy to announce, as many of you would already know, that we now have personalised accounts for HealthPathways. So the old generic logins that were used for years no longer work. Many of you would have already registered for an account. There's contact details at the end if you're having trouble with that, and I'll explain in a few moments what some of those benefits are. A question we often get is, which HealthPathway site should I use? And it really depends on where your patient is going to be receiving services. So even if you're a GP, for example, in, say, the Camperdown area, which we would say is the Sydney Local Health District catchment, but you need to refer a patient to, say, the Royal Hospital for Women for a particular reason, you would then check Southeastern Sydney, because that's where the local referral information will be displayed for that region. So it really just depends on that. Again, any issues such as that, if you're not sure which site to use, please do contact one of your local teams. We're more than happy to help. And there's no restrictions, so you can use both sites. We have a lot of users who across metropolitan Sydney will use multiple sites just to see, you know, the different services across metropolitan Sydney. I just wanted to mention that tonight's presentation by our fantastic speakers is going to cover processes with respect to the Sydney Local Health District. So that's your RPA, Canterbury, Concord region. It's very specific to that, and we can answer questions later if there's anything specific about regional variances. As I mentioned, we've got some exciting news. So obviously tonight's presentation is going to focus heavily on the soon to be launched National Lung Cancer Screening Program. I'm very pleased to announce we are very, very, very close to having a brand new pathway on lung cancer screening, which will take you through all the steps, all the processes, what to do with various incidental findings. I've also listed here, we've got a range of other related pathways that may be beneficial in this area. And just to mention, these slides will be provided to attendees, so you'll be able to click on these hyperlinks and have a look at these pathways yourselves in your own time. I just want to add a quick note with respect to low-dose CT radiology, which will be covered in tonight's presentation. We're currently scoping the services that we'll be offering that for the national program. It's a bit of a watch this space at the moment. We know we're very close to launch, but we are trying to collect that information as we speak. So just bear with us, and we'll be really excited to let you know once we've got that lung cancer screening pathway live, which again will come through as an email to attendees tonight. For those in the southeastern Sydney region, very similar content here. They're also working on a lung cancer screening brand new pathway as well, and you can see some of those similar related pathways as well. So just a quick note about these individual logins that I mentioned earlier. As I've already said, the former generic logins that used to work for years, and that was like the connected healthcare, that's now gone. The only way to access Health Pathways, both for Southeastern Sydney and Sydney, is via a registered account. The great thing is that you only need to register once, and then after you've done that, you'll be able to access multiple other sites if you want to by just clicking a quick form from there. Once again, any issues with access, just contact your local team. Some of the new features that are available through these personalised accounts include Smart Search. So I've given a bit of a demo there. I'm sorry if it's a little bit small. So when you search something now in Health Pathways in that top search bar, you'll get the first thing you'll see, which I've got highlighted there. It says try Smart Search. And using the search term that you've put, it's going to find various indications and it'll actually point you to the section of the pathway of that particular search word. So we encourage everyone to have a bit of a play with that new feature. The other exciting feature, which some of you may have already used, is everyone with an individual account has access to CPD reporting. So on every pathway in the right-hand corner, which you can see on that first screenshot there, you've got an option to create a CPD report. That will then take you to a portal which is linked to your account, and it actually shows you a log of everything that it's recorded in terms of your time spent looking at pathways. Now, it goes without saying that if you minimize your browser whilst looking at the pathway, or it detects a period of inactivity, it's not going to keep recording. So even if you've had a pathway open all day, but you sort of come in and out of it, it's not going to log 8 hours, for example. It does have a system where it's looking at activity on the page. The great thing about that is you can generate a personalized CPD report, which logs that use, and then you can add individual reflections, say, depending on what the pathway was. You can add your own learning notes and then satisfy RACGP requirements that way. Last but not least, some contact details just there on the screen. We always welcome feedback, troubleshooting, anything you need. As always, once again, on every single pathway that you see at the bottom, there's the send feedback blue button. That comes straight to our teams. We triage that and aim to get back to you as soon as possible. As I mentioned, these slides will be sent out to attendees, so no need to rush down and copy those details, but we'd love to hear from you. Any questions at all, we'd be more than happy to help you. That's me.
Thank you very much, Tammy. Very important update. And we already have first question regarding Health Pathways. And I would like to invite everyone, if you have your questions for regarding Health Pathways, please post them to the Q&A, and Tammy will answer it for you. We would like you to secure Tammy for the length of tonight's session. So thank you again. And moving on, I would like to welcome our facilitator for tonight, our local GP in Inner West, Dr. Claire Stewart. Claire is one of the GP advisors in CPD education for the Inner West region. Take it away, Claire. Thank you.
Thanks, Lydia, and thanks, Tammy. As Lydia said, I'm a GP in the local area. I am on the CPD committee for CESPN, and I'm facilitating tonight. So we've got a couple of really good speakers tonight who are going to speak to us about the new lung cancer screening program, which is just about to start formally. So I think it's going to be really informative and helpful for us going forward. So we've got Dr. Alice Cottee and Dr. Elizabeth Veitch, who are both respiratory and sleep physicians from Concord Hospital. Alice is going to go first. I've got a really quick bio for her, so I'll read that out and then we'll go from there. So Dr. Alice Cottee is an adult respiratory and sleep physician at Concord Hospital and Director of Clinical Trials and Research for the Respiratory Department. She has extensive experience in the assessment and management of airways disease, breathlessness, pulmonary embolism, lung nodules, and lung cancer, in addition to general respiratory and sleep conditions. She completed her PhD in airways physiology, examining the clinical utility of respiratory oscillometry in asthma management. Her research interests include asthma and COPD, pulmonary embolism, clinical innovation, and translational research. So we'll hear from Alice first, and then we'll hear from Liz after that, and then we'll have questions at the end. So as Lydia said, any questions into the Q&A box, and we'll do them at the end of the presentations. Thanks, Alice.
Thanks very much, Lydia. I will apologise to everyone in the first instance because I have laryngitis and hopefully my voice will last the distance. So thanks for asking me to speak today. This is a very exciting area, although I know anxiety provoking for the rest of the medical world because it's very new, but it's really exciting area for our patients, which we deal with. And really, I've retitled it A New Dawn because it's a new sense of hope for our patients in the respiratory land. So what do we know about lung cancer in Australia? First of all, it's the 5th most common cancer. It was about 13,000 new diagnoses every year, up to 15,000 on the most recent statistics. And it's the leading cause of cancer death in Australia. But above all, it's the 5th leading cause of all deaths in Australia. But the sad thing for patients who are unfortunate enough to develop lung cancer is they have the worst 5-year survivorship of the most common cancers. So only 20% of patients with lung cancer see 5 years from diagnosis. Whereas we look at the other common cancers like breast cancer, prostate cancer make it up to about 90%, melanoma 90% with new treatments, and bowel cancer 70%. And really, why is this? Well, because lung cancer is very sinister and it's detected too late because patients don't develop symptoms until they have more advanced or metastatic disease. So without a screening program, up to 75% of cancers are already locally advanced or metastatic at diagnosis. And why is this important? Well, survival rates relate to stage at diagnosis. So if we look at international data here on this Kaplan-Meier curve, you can see here that those patients who are diagnosed with stage 1 disease have a much better 5-year survival than those with stage 4 disease. We're almost less than 5% make it to 5 years. If we look at this in the Australian context, we see similar data. This is from Cancer Australia. So if you're diagnosed at stage 1, you have a almost 70% 5-year survival, as opposed to those diagnosed at the later stages, stage 3 and stage 4, which is what we see more commonly. You have anywhere between a 3 and 15% 5-year survival. So this is really the whole basis of lung cancer screening, identifying lung cancer in at-risk individuals early to improve their prognosis. So where's the evidence behind lung cancer screening, and do they work? The first thing to say is the concept of lung cancer screening isn't new. Clinicians have been looking into screening opportunities since the late 1960s. And even up to the 1980s, there were no survival benefits shown. And this was predominantly because they were performed with chest x-rays and sputum cytology. So basically the chest x-ray was not sensitive enough to detect a lung cancer until it was more advanced. And then CT scanning came along, but again, it took a number of years for studies to finally find the right target population and protocols to demonstrate any benefit. So this is the Sentinel screening trial. There are a couple, but this is the one I'll focus on. So this is the National Lung Cancer Screening Trial, published almost 15 years ago. It's the largest US trial of over 50,000 patients. In this cohort, they identified patients who were in the age range of 55 to 70 years old. They'd smoked at least 30 pack years and were either a current or ex-smoker who'd stopped less than or equal to 15 years ago. And if they qualified, they were randomized to either an annual low-dose CT scan or a chest X-ray. And these patients were followed for 3 years. So what did they find? Well, perhaps not unexpectedly, there was a greater positive screen rate of abnormality in patients who had a low-dose CT scan, which was 24%, as opposed to 7% who had a chest X-ray. Interestingly, though, the false positive rate was similar for both groups with further investigation. And so if we look at these graphs here on the right, you can see that over the time since randomization, the cumulative number of cancers detected were greater with low-dose CT scan than chest radiography. And this resulted in a lower rate of deaths, in the order of 20% less cancer-related deaths over the duration of the study. So low-dose CT scan, this was a sentinel study because it demonstrated for the first time that not only could low-dose CT scan detect lung cancer at an earlier stage, but it was the first one to demonstrate a relative reduction in mortality with that. An important thing to note, which came out of this trial and other trials, is that having a high detection rate does not reduce the ongoing need for screening. So you'll continue to pick up new nodules and new cancers across the course of screening. But what you are seeing is in the subsequent years of screening, you'll see fewer stage 3 and 4 cancers. So there have been a number of studies. There's also another study, another large trial called the Nelson trial, which was a large Dutch-Belgian screening trial. And they looked at changing the interval of CT scans. And what these two large studies have told us, that combined information of these two large studies, is that CT screening, low-dose CT screening, detects lung cancer at an earlier stage. It can reduce lung cancer mortality in the range of 20 to 30%, depending on the protocol. That scans should not be more than 2 years apart. One arm of one study demonstrated that if you stretch the scans further apart, you ended up developing more incident and later stage diagnoses. So 2 years is the optimal range. The other thing it demonstrated was that these cancers that are being picked up are a different phenotype to the cancers we historically are used to thinking of as being caused by cigarette smoke. So they were predominantly adenocarcinomas and they were more peripherally located. And this is important when we think about how we're going to investigate and manage these nodules in the future. And so there's been lots of economic algorithms, and the consensus from this experience is that the most clinically and cost-effective programs are targeted towards high-risk populations. So this brings us to the Australian National Lung Cancer Screening Program, which I know is why we have such a large audience today. So as you know, this launches on the 1st of July, and it is based around a free low-dose CT scan every 2 years for individuals who are at high risk of developing lung cancer. So the guideline, the criteria which have been chosen in Australia, which is not based on any specific trial, but based on the healthcare economics of several different trials, was patients who are 50 to 70 years old with no signs or symptoms of lung cancer, have at least a 30-pack year smoking history, are a current smoker or who have quit smoking within the last 10 years. Now, this is the first cancer screening program in Australia for 20 years. So you can imagine there have been many groups involved in its rollout. It's just over 2 years since the government announced it would support the program. And so there have been multiple advisory groups and committees in terms of its rollout. So you'll see many different groups involved in design, development, representation. It's being linked in with the National Cancer Screening Register. And at this point in time, the government's committed to funding this program for 5 years. So the Australian Institute of Health and Welfare is also monitoring the program and evaluating its use and efficacy. Cancer Australia, Lung Foundation Australia are involved, and the Daffodil Centre is developing information materials, particularly for patients of non-English speaking background. And the Aboriginal Health Organisation has been involved, as well as Heart of Australia, which is providing the coordination of lung cancer screening services in the form of mobile screening in the country. Sorry, I lost my slide. So the guidelines cover multiple aspects. There's a screening assessment pathway, there's smoking cessation advice and support, there's shared decision-making requirements and information for that for patients. There's the CT referral form, there's recommendations and practice points. It links into existing pathways and guidelines already available as well. So this was published about a month or two ago, but it's a nice schematic summary of the screening and assessment pathway. And I'm sure that this will be sent to all GPs in some format as the program gets up and running. And I've already written a schematic of this in an individual form, but altogether it combines to look like this. So this is the program entry. So the first thing to say is that the participant is identified and recruited. Now, this will predominantly be through general practice, but there is also the opportunity for specialist referral as well. And it can either be in an organised manner, trawling through patient records, through the practice software, opportunistic if a patient presents, facilitated if the practice has the opportunity to do so, or self-identified by a patient presenting. As with anything in healthcare, there is a strong emphasis on shared decision-making with the patient, and there will be patient information available for this to provide an opportunity for informed choice and consent. And at the end of the talk, I'll show you some of the patient information brochures which are starting to become available. There's the suitability assessment. Can a patient have a CT scan? Are they able to lie flat with their arms above their head for 5 minutes, for example? Are they less than 200 kilograms and therefore can have a CT scan? If the patient meets those criteria, then a national cancer screening data form has to be completed. So you can log into this through PRODA, or my understanding is that you have the opportunity to link your practice software with the NCSR as well, and complete that, and then following that, complete a low-dose CT scan request form. And as part of entry into the program, smoking cessation is also encouraged, as at the end of the day, this is the greatest chance of preventing progression of any lung disease in the future. So, as I mentioned, all patients must register with the National Cancer Screening Register. Actually, I should reword that. All patients are strongly encouraged to register with the National Cancer Screening Register. If a patient chooses not to register, then they can still have Medicare-funded low-dose CTs, but it's up to that individual medical practitioner to order them and monitor them in accordance with the recommended guidelines. So you and the patient will not get any notification of their scans being in the National Cancer Screening Register, nor will the patient get reminders when their next scan is due. So there's a very strong emphasis on ensuring all patients register with the National Cancer Screening Register. And the other aspect of that is that if they're not registered in the National Screening Register, the benefits of the program are not as well elucidated. So that's important for future funding. So assuming a patient has registered with the National Cancer Screening Register, then the National Cancer Screening Register forms two parts. It will, if a patient has a normal CT scan, then they will get a notification from the National Cancer Screening Register that they have a normal CT scan and they don't need another CT scan for 2 years. Alternatively, if they might get a notification that there's an action needed and to contact their GP. If they're in that normal group who only need a scan in 2 years, then they'll also get a 2-yearly reminder. And then the other part of the National Cancer Screening Register is all information and CT scans are uploaded into that, the reports, sorry, are uploaded into that National Cancer Screening Register. Okay, so the low-dose CT scan. So in order for MBS funding for the low-dose CT scan, there will be 2 new MBS items on the 1st of July. The first is for the low-dose CT scan every 2 years. The second is for an interval CT as dictated by the report on the previous low-dose CT scan. If a patient has a low-dose CT scan performed under the National Lung Cancer Screening Program, all radiology practices must bulk bill that scan. So there will be no out-of-pocket costs for any patient participating in the National Cancer Screening Program in regards to radiology. So this is the low-dose CT request form. Not that different to a usual CT request form. They ask about Aboriginal Torres Strait Islander ethnicity. They ask you if they meet the eligibility criteria. Sorry, I'll just zoom in on that one. I've got it. They ask you if they meet the eligibility criteria, if this is a new participant or a 2-year scan, or if it's an interval scan, where they've had their previous CT chest, if they've got a family history of lung cancer or any history of lung cancer. And this is all important, especially for the initial scan, because it helps determine the risk that a nodule identified on the first scan is whether it's suspicious or not, its chance of being malignant. At the bottom, I'll just go back one slide. At the bottom of the scan, of the CT request form, there's also a disclosure. You can see me circling down here, which basically says that the patients, by having the scan, is agreeing for any healthcare provider, including a different radiology practice, to potentially access their scan if needed to compare it to a previous scan. On the left here, I've just put some reasons here to delay enrolment. So there are some government requirements. If a patient has had a full CT chest in the last 12 months, then their enrolment should be delayed until that 12 months has elapsed. Similarly, if a patient has a CT chest planned for another reason in the next 3 months, they shouldn't be enrolled. And finally, if the patient's had a chest infection in the last 12 weeks, again, please delay the scan for another 3 months because we don't want to see incidental nodules. And there is a category, if a radiologist thinks that a scan is due to infection, they'll actually send it back to you and ask them to do another scan. I'll show you the structured radiology reports later, but what you'll see when the results come back to you is a very structured report, which there's been a lot of thought put into by the radiologists. It gives you a description of the nodule, its malignancy risk, recommendations. It will also have additional findings and identify whether they're actionable and what the referral recommendation is. The CT scan will be sent to the referring medical practitioner and also uploaded onto the National Cancer Screening Registry. So there are two different nodule risk assessments that will be performed. So on the very first baseline scan, they'll perform a PanCan risk model assessment. And this is using all the information you can see here on the right that has been provided on the referral form. So it's very important to provide that information. And it estimates the cancer probability using a combination of patient and nodule characteristics. This model has been picked because it has the highest sensitivity for baseline scans in terms of predicting malignancy, but also it has similar outcomes to other risk models, but with less CT scans. And it's a well-validated international model. The follow-up scans will all be assessed using lung RADS. And this is an international classification system used by the American College of Radiology, which incorporates malignancy risk with standardized reporting and follow-up recommendations. So in terms of results notification, as I already mentioned, all results come back to the GP, but if they're identified as normal, the patient will receive notification from the National Cancer Screening Registry, assuming they agree to be part of the registry. And then they'll also receive a reminder for their next scan in 2 years. If it's abnormal, the patient will receive notification to go and follow up with their GP. Okay, so this is where we get to see how they stratify each different kind of scan, every individual scan. So in there will be a small proportion of patients who are classified as incomplete, and this is either because not all of the lung could be evaluated, or they had suggestions of inflammation or an infective process, so they're asked to come back for a repeat CT scan. Then there are those patients which are very low risk, and these are patients with either no nodules or benign nodules. And when we say benign nodule, it's a nodule with a PanCan risk of less than 1.5%. So these individuals will have a scan in 24 months. Next, there is the low risk cohort. So they need to come back in 12 months. Moderate risk, having a risk of a PanCan risk of 6 to just under 10%, and they come back in 6 months. Nodules with a risk of up to 30% need another scan at 3 months. These are the majority of patients in this cohort, and they will actually stay within the National Lung Cancer Screening Program. It's only those patients who, and it will be with the GPs to continue to order and request the low-dose CT scans as recommended by the pathway. A minority of patients, those who are high risk or very high risk, and these are patients where the nodule has greater than 30% chance of being malignant, or it's got additional features or findings that have an increased suspicion for cancer. These patients, the report will instruct to refer back to a respiratory physician. And then finally, there are the additional actionable findings. So one reason the National Lung Cancer Screening Program has taken so long to be established is because, unlike every other cancer screening program we have, when we think breast, bowel, cervical cancer, prostate cancer, for example, it doesn't just screen the lungs, it screens the whole chest. So it's not organ specific. So we expect there will be many additional actionable findings found as part of this screening program. And you will see, this is the risk that comes up on the subsequent scans. You can see here, same scales, slightly different criteria because it's using a different model for the follow-up scans. But again, very similar protocol in terms of follow-up timing of scans. So I just wanted to touch here on the types of lung nodules that will be reported. So there's the ground glass nodule, which can be reported as non-solid. And essentially this is an area of haziness, increased pulmonary attenuation, but where you can still see the preserved bronchial and vascular markings underneath. The next type of lung nodule you'll see reported is a part solid nodule. So again, this is a ground glass nodule, but it's developing some solid components. Another nodule, and usually often a more concerning nodule, is a solid nodule. And what differentiates that from ground glass and part solid nodules is that it's dense. It's got a density comparative to a blood vessel, and it obscures the lung parenchyma within it. And then finally, I have here an atypical cyst, because this may be something that you see on your reports. They're not as common, but they are associated with increased risk of lung cancer. And so it's a thick-walled cyst, often multiloculated and associated with a nodule. So that's something else which might pop up. So as you can sort of gather here, and from the previous slides, there are certain characteristics which will determine the risk of a nodule. So the nodule's appearance, the nodule's size, and upper lobe location is more likely to be associated with malignancy, particularly in smokers, speculation, and number of nodules. And so these will all go into the PanCan score at the beginning with their first scan and be used to determine the risk. But ultimately, after the first scan, the biggest predictor of malignant potential is growth of any nodule. I wanted to touch on incidentalomas for you. So the first thing to say is incidentalomas are expected. And there's going to be a wide range of findings, from thyroid nodules to breast nodules to osteoporosis to we're going to find other lung diseases such as interstitial lung diseases and bronchiectasis, coronary artery calcification, and of course renal and liver cysts and other findings. But what I think you should take reassurance from is that the structured radiology report will clearly state any incidental findings, if you need to take action or not, and what that action should be. And there's actually guideline management for incidentalomas as part of the National Lung Cancer Screening Program. So this is an example of a structured radiology report. So at the top, there will be the clinical history, which is provided on the referral form. It will indicate the radiologist and the formatting of the CT scan performed. Then it will move on to nodule findings. Is there any evidence of infection or inflammation? In this case, no. Are there any nodules that are considered benign? In this case, no. Are there any pulmonary nodules for follow-up? Again, in this case, no. And then they will, below that, they'll state, are there any additional findings? In this case, no. And then at the very end, there will be a summary, a conclusion. So for this patient, they're category 1, which is very low risk, and they require a 12-month CT scan. There will also always be a reminder at the bottom of each radiology report encouraging you to remind the patient to return to the same imaging provider. So in New South Wales, our imaging is not pooled in any centralised radiology bank. So it's obviously much easier for a radiologist to compare scans if they have the prior scan available to them. And so just moving on to another report. So this one's a bit different. They did find some benign nodules, and they tell you they're benign and why, and they give you a description why they're benign. They're scattered sub 3 millimeter calcified granulomas. So the screening program, in keeping with international guidelines, will not report any nodule as suspicious unless it's above 4 millimeters or 34 cubic millimeters. This patient, you can see, does have a suspicious nodule, which needs follow-up. So it gives you, it lists the slice, the location in the right upper lobe. It's part solid, it's spiculated. It looks at the PanCan risk here. So the PanCan risk is 24%, and so it falls into screening category 4. This patient also had an incidental finding. They've got a density in the left upper pole of the left kidney. So at the end, it summarizes all of it for you. This patient is category 4 and needs a repeat low-dose CT scan in 3 months. And it will also tells you there's actionable findings. And the patient needs a renal ultrasound for their indeterminate kidney lesion. What happens if a patient has a finding which is even more concerning? So this patient also had pulmonary nodules, none which were considered benign, but 2 which were concerning. So nodule A is category 5. So this is performed on a subsequent scan, not the first one, and they've calculated a volume doubling time and making it fall into category 5. The second nodule that they've got at this point in time is not so concerning and remains in category 2. They've also noted that there's moderate atherosclerotic plaque in the coronary arteries. So the conclusion that you will see is that this patient is category 5 and you need to refer to a lung cancer multidisciplinary team. It will also give you some recommendations in terms of moderate coronary artery calcification. So recommending clinical review, lifestyle modification, and pharmacotherapy. So the resources which are going to be available are starting to appear. Not all of them are available yet, but these were some which I found so you can see. So patient information is starting to become available. So you can see here, there are 2 different kinds of screening program brochures. This one here, a more detailed one. This one just highlighting why we should do lung screening and what's the benefit. This I thought was a patient information brochure which was useful for you to be aware of. It's why am I currently not eligible for lung cancer screening? Because the lung cancer screening program at this point in time is a very targeted cohort of patients. And that is obviously a great place to start out, but there are other patients who may wish to have lung cancer screening but are not eligible under the program. And so this brochure explains it to them and then asks them to discuss it with you as a health practitioner. I'm not sure if it's in this particular brochure, but in other patient information, it explains that they should consider if they want to have screening, continue to discuss it with you, and talk to you about patients who may be at lung cancer risk or have a risk of lung cancer, but who aren't part of this screening program. And 2 particular groups stand out. Those patients who have a strong family history of lung cancer, That's about 30% of patients so 30% of people in Australia who develop lung cancer have no smoking history. But those patients are excluded from the program at this point of time. And the other group of patients who have a risk of lung cancer are those with occupational exposures, and they're excluded as well at this point in time. So if the program is successful, we hope that it will grow and target other groups, but at this point in time, they're excluded. So this brochure will be helpful for those patients to understand where you are bound within the program, but you can discuss the benefits and risks of screening for the other risk factors in a different way, separate to the program. And this is quite a nice brochure which summarises everything going through the different steps in the screening process. I found this, and I think this is quite useful for you as a general practitioner. Looking, and to give to your patients, it's a quick, and it's a way of them having some autonomy and decision making in regards to lung cancer screening. So it explains to them what's the point of lung cancer screening, if they're eligible, and then how can screening help? And it takes them through a set of different decision making questions, which I wish I could blow up, but I can't now. But explains to them, asks them how important or not important these different aspects are. And depending on where they score, it helps them align and see whether they want lung cancer screening or not. So it's something a patient could do in the waiting room and come, you could have them in the waiting room and they could come and speak to you and say, actually, this helps me make my decision. So that's been a little bit of a whirlwind through the lung cancer screening program. One thing I haven't mentioned up to now is that we expect 50 to 60% of patients who are in the screening program will have a nodule. Lung nodules are incredibly common. But what we have to take away from this and inform our patients is that the majority of these nodules that we find won't be malignant. However, we want to identify those nodules as early as possible so that we give each individual patient the opportunity for earlier intervention and better long-term survival. The other thing we should be confident in as medical practitioners, and also with respect to how we convey this to our patients, is that the screening program is based on solid evidence. These programs have existed for almost 15 years, or over 15 years, in multiple countries around the world. And our screening program and the intervals we recommend is based on solid evidence. So we should be confident to say to our patients, this is based on evidence and we will follow the screening pathway. You will see more information as it becomes available. One thing which hasn't been released yet is the Daffodil Centre's information for culturally and linguistically diverse populations. And this information will be very important within our districts. If the modelling is true, which we suspect it will be, we will prevent over 500 deaths a year from lung cancer. And we will shift from seeing only 15% stage 1 at diagnosis to over 60% stage 1 at diagnosis, as opposed to the current status quo, which is about 50% at stage 4 at diagnosis. And with time, this will shrink to about 10%. And finally, I'd like to say that I know there's significant anxiety within the medical community about the amount of work this is going to generate. But I think in reality, the uptake of the screening program will be gradual. And you will be able to learn with your peers, with all of us as we go along. It's not going to be a sudden flood of patients entering your program, And so you will be able to build up your confidence in the program, how to navigate all the different modules as your patient numbers increase. As Tammy has already highlighted, we will have HealthPathways lung cancer screening modules available to help you through this program. And so in our module in the Sydney Local Health District, all these main information sheets, the radiology forms, etc., will all be linked in as well. So you've got easy access to them, and so that you can print them out for the patient depending on their situation. Just to touch very briefly, I wanted to let you know about a module that we have in Sydney Local Health District, which Liz and I have developed with Yudi Chen and Lauren Walker. And this is for just pulmonary nodules, which are found outside the National Lung Cancer Screening Program. Because let's face it, we see pulmonary nodules every day of the week. And it's nice to have a resource which is simple and easy to look at with a patient in front of you. So this resource that we've developed is based around the Fleischner guidelines. It's currently used by respiratory physicians and radiologists to assist with decision-making in regard to nodules. And it's there and available for you to use for incidental pulmonary nodules. Or perhaps if you have a patient who doesn't meet the clear current National Lung Cancer Screening guidelines, but is having screening for another purpose. And then the final thing I wanted to mention is what we're doing at Concord Hospital. We've spent a lot of time over the last 18 months preparing for the rollout of the National Lung Cancer Screening Program. So for the last year, we've been running 2 nodule clinics a week. And the purpose of this is to separate nodules out from our lung cancer, because we can manage them through different streamed pathways. And aligning with this, we've been running a dedicated lung nodule MDT, which is separate from our lung cancer MDT for the last year. And so clinicians in our district who have affiliations with our hospital or who work at Concord Hospital refer patients to the lung nodule MDT, where they're discussed with respiratory physicians, interventional pulmonologists, radiologists, and nuclear medicine physicians about the appropriate way to either monitor or investigate the nodule. Because one thing that just as the lung cancer screening program is rolling out, the opportunities for investigation are also changing. So Concord Hospital is a leader in interventional pulmonology, and currently is the only public centre in New South Wales to offer CT guided biopsy through bronchoscopy. And so there are new options developing. So patients can have percutaneous biopsy, or in the future, currently only at Concord for public patients, but elsewhere in the future, we'll see other options for investigation of lung nodules become available. And this is where a lung nodule MDT is very important to decide which option is the best for each individual patient. We also host a smoking cessation clinic for patients who nodule service, because again, it's never too late to stop smoking and prevent future damage. And finally, we have been planning for increases in all these interventions that are going to be required for suspicious nodules, and streamlining our services to facilitate this.
Thank you, Alice. And second part of our presentation will be coming from Dr. Elizabeth Veitch. Thank you.
Hello, everyone, and thanks very much for the invitation. So I'm acutely aware that what you really wanted to hear about tonight was the National Lung Cancer Screening Program. But I was asked to say a few words about lung cancer. And so this is a bit of an update, and we will sort of go flying through lung cancer. And I hope to give you a sense of how things have changed enormously and where we might be going in the future. Thanks, Lydia. So there's certainly been, since I graduated, a marked change in the epidemiology of lung cancer in Australia. For sure, we've seen increasing numbers due to population growth and aging, but we've also seen rising numbers in non-smokers. So when I graduated, about 5% of lung cancers occurred in non-smokers, but we're now up to 20%, and that figure will probably continue to rise. There's been marked changes in the pathology, which previously squamous cell carcinoma was the most common pathology, but now adenocarcinoma is the most common, accounting for around 50% of cases. And whilst a dismal disease, we have seen increasing survival over time due to improved treatments, especially treatments that are targeted to specific genotypes in non-small cell lung cancer. So as Alice has said, lung cancer is very common in Australia, and it is dismal. It's nearly, it causes nearly double the number of deaths per year than the other nearest leader in cancer deaths, which is colorectal cancer. So it's really something that you don't want to get. It has the worst 5-year survivorship of the most common cancers. So most of the common cancers have 70 to 95% 5-year survivorship, whereas last year lung cancer 5-year survivorship was around 26%. There are a few other equally dismal cancers like pancreatic cancer, but you can see we've got a long way to go. However, one glimmer of hope is the fact that when I graduated, the 5-year survival rate was much lower. So we have made some significant progress in the last 20 years. And as Alice said, this really relates to finding these cancers too late. Thanks, Lydia. So when we do, when a cancer does sort of come our way, or nodules that are suspicious come our way, I thought we'd just spend a few minutes talking about how we might go about finding out what we're dealing with. I mean, there's like the old sputum cytology, but we really don't do this very frequently at all because its pickup rate is quite low and obviously variable. Bronchoscopy is very useful, although standard bronchoscopy perhaps less useful now than it used to be. So when I graduated and we had a lot of squamous cell carcinomas, these tended to be central, and so standard bronchoscopy was very useful. However, now that we're dealing with a larger amount of adenocarcinomas, these are more likely to be peripheral tumours, and so we need other ways of finding the answer. We now do biopsies from mediastinal lymph nodes, so-called EBUS of the lymph nodes, and that is very useful because with that procedure, you can both make a tissue diagnosis of a cancer if it's spread to the lymph nodes, and you also can potentially stage the patient at the same time. And that's got particular relevance when you're thinking about whether a patient might be able to have their cancer resected or not. There's obviously percutaneous nodule biopsies, which we've had for many years, and biopsy of metastasis. But CBCT or cone beam CT guided lung nodule biopsy, that is really the sort of new kid on the block. Thanks, Lydia. So I've just put up a few pictures here where you can see in the top of the screen a number of different suspicious lesions that are very amenable to percutaneous fine needle aspiration, or more commonly now, patients would have a core biopsy, which obviously an FNA achieves cytology, but with a core biopsy, you've got histopathology. And so that's increasingly what's done. Down the bottom, you can see a PET scan of a patient who has a very avid tumor, but you can also see sitting in front of the trachea, between the trachea and the major vessels, that there are some very hot lymph nodes there, and they're almost certainly metastatic. So rather than targeting the very large mass in the lung, a person like this would have an EBUS of the hot mediastinal nodes, which would make the diagnosis, but also stage the patient at the same time. Thanks, Lydia. So I wanted to just tell you a little bit about CBCT, because you will be hearing more about it. And I suppose to start off, there's been a study that was published in the New England Journal only, a couple of months ago, the Veitch study. And what this did was they looked at the diagnostic accuracy of what they call navigational bronchoscopy. We tend to call it CBCT, guided lung nodule biopsy. And so these are procedures that are done as day-only procedures in theatres. So the patients are fully anaesthetized, they have a bronchoscopy, but we're now using these very fine bronchoscopes that allow us to go right out into the periphery. And with the help of cone beam CT, you can guide the biopsy forceps to very small nodules. So this study, the Veitch study, looked at over 200 patients, and it found that the diagnosis rate was not inferior. In fact, it was marginally better with CBCT as opposed to percutaneous biopsy, 79 versus 73%. And when they looked at the pneumothorax rate, there was a significant benefit having a CBCT procedure over a percutaneous biopsy. Now, we shouldn't be all aiming to throw the baby out with the bathwater. I mean, percutaneous core biopsies are still an excellent procedure, and one of the criticisms of this trial was that their pneumothorax rate was actually much higher than we generally would experience, I think, certainly at Concord Hospital, and I'm sure at most other hospitals in Sydney. But nonetheless, I think you will see more about CBCT in the future. Thanks, Lydia. And this is really as just a plug for our own hospital, because as Alice said, we were the first public hospital in Australia to offer this procedure. It's not available in many places at all. And in fact, we've just recently celebrated our 100th case. So it's a fantastic effort for our interventional pulmonology team. Thanks, Lydia. Having said that, I mean, patients don't like being poked with needles, and I think it would be wonderful if we could ultimately move away from that sort of diagnosis. And so I thought I'd just mention one of the new kids on the block is multi-cancer early detection tests. So we know that existing cancer screening programs are effective, but they have a number of issues. They only look for one cancer, so you need multiple different programs, and so running these becomes complex and costly. And existing cancer screening programs also trade off specificity for sensitivity. For example, in lung cancer screening, most of the nodules we find won't be cancers. If you're looking for colorectal cancer with fecal occult blood tests, well, you're going to find much more hemorrhoidal bleeding than you are colorectal cancer. So that's one of the issues. Multi-cancer early screening tests are intended to screen for various types of cancer simultaneously. They're blood tests which can detect cell-free cancer DNA, and they can also test that DNA for specific mutations. They're currently not intended to replace existing cancer screening programs, but potentially to be used concurrently. Thanks, Lydia. So there are advantages, like any test, there are advantages, disadvantages, and uncertainties. So the hope is that they might lead to earlier cancer diagnoses and avoid lots of scans and invasive procedures. They do already exist, and one of the disadvantages is that they're very costly. There's also the concern that they might lead people to have false reassurance and potentially thus delay seeking a review of concerning symptoms. And there's certainly still uncertainties about their efficacy in detecting early cancers and their efficacy in reducing cancer-related mortality. Having said that, the NHS in the UK and the US National Cancer Institute are both looking at multi-cancer early detection tests to assist them in screening for cancers and more recently in also screening for various molecular markers in breast cancer that haven't responded to previous therapies. Thanks, Lydia. So we'll move on now. If we've sort of talked a little bit about finding cancer and diagnosing cancer, and now let's talk a little bit about cancer staging. And I'm sure all of you are very familiar with the TNM system, which was introduced in 1987, and it provides a universal nomenclature to describe the anatomical extent of cancer. But revisions are constantly needed as our understanding of cancers and their management options becomes more nuanced. Thanks, Lydia. So you can see Alice has already showed you some of these slides, these survival slides. So the 7th edition, we're actually now up to the 9th edition, but the 7th edition of the TNM staging for lung cancer came out in around 2010, and it was a significant revision which included a finer subdivision of tumour size categories and differentiation of metastasis into intrathoracic or extrathoracic. And then in 2017, the 8th edition came out, and it further refined the size-based categories for the tumour and made a distinction between single and multiple distant metastases. Thanks, Lydia. So what do we have now? Well, we've now got the 9th edition, which came out on the 1st of January of this year. And so you can immediately see, thanks, Lydia, that the areas that have changed are in dividing up N2 and also further divisions in metastatic disease. Thanks, Lydia. So in particular, we now divide N2 into single station or multiple station involvement. So we now have a much more precise understanding of nodal involvement, and that can influence treatment choices. And the M1 subdivision now is into multiple metastasis in a single organ and multiple metastasis in multiple organs. Thanks. So in terms of, so we've now talked about, you know, how do we diagnose cancer, and now how do we stage cancer? And I guess the only other thing I wanted to say about staging, which I forgot to point out at the time, was how very complex it now has become. So if you look at, say, a patient with a 2B tumour, a 2B stage cancer, a patient can get into that stage by having a very large cancer over 5 centimetres, but having no nodal disease or distant metastasis. They can get into the same group by having a moderate sized cancer, say 3 to 5 centimetres, but having some hilar lymphadenopathy, or they can get into that group by having a small cancer less than 3 centimeters, but having some hilar and mediastinal lymphadenopathy. So you can see it's become quite a complex system. In terms of cancer management, Lydia, go back. Sorry, in terms of cancer management, you'll all know the mainstays are surgery, radiotherapy, chemotherapy, and certainly over the years, beyond the scope of our talk, there have been major improvements, improved surgical techniques, now using keyhole surgery, more recently robotic surgery. Radiotherapy improvements have included much better targeting of lesions, so-called stereotactic ablative body radiotherapy, or SABR, and that results in improved outcomes and fewer adverse effects, and chemotherapy improvements have occurred as well. But the place of big improvement has been in new drug development. Thanks, Lydia. So, and this is predominantly new drug development in non-small cell lung cancers. And you'll recall that non-small cell lung cancer accounts for about 85% of lung cancers. So around 20 years ago, the discovery of epidermal growth factor tyrosine kinase inhibitors and the recognition of the role of EGFR mutations in lung cancer really marked the beginning of precision medicine in lung cancer. And since then, there have been multiple landmark trials which have further refined our management of non-small lung cancer. The earliest trials focused on metastatic or advanced stage cancer, but more recent trials have shown survival benefits in earlier disease. And so at this point, any patient with stage 2 to 4 non-small cell lung cancer should be considered. Their appropriateness for these therapies should be considered. The therapies fall into 2 broad groups: immunotherapy, which is predominantly the immune checkpoint inhibitors, or targeted therapies to specific molecular genetic alterations. So if we talk first about the immune checkpoint inhibitors, we know that T cells circulate through our body looking for abnormal cells or organisms to destroy. And these T cells carry checkpoints or proteins on their cell surfaces, which prevent them from attacking normal cells, sort of like a brake on the T cell. And cancers have learned how to use these checkpoints to prevent T cells from destroying them. However, we now have checkpoint inhibitors which can block these checkpoints so the immune system can once again recognize these cells as abnormal. Thanks, Lydia. And so you will have heard some of the names, I'm sure: pembrolizumab, nivolumab, durvalumab. And so you'll probably have had some patients on these. They're quite expensive drugs. They're heavily subsidized for the PBS and usually given for specified periods of time. They're given intravenously in cycles several weeks apart, and they can be given singly, or they can be mixed with other ICIs or mixed with targeted therapies or chemotherapies, and they can be used now in neoadjuvant and adjuvant settings. They'll commonly lead to progression-free survivals of 12 to 18 months, but it's very variable from person to person, and it can be much longer. There are, however, a lot of side effects because of their mode of action on the immune system. To some degree, most patients will experience some side effects, and you can really get any itis from these drugs. Thanks, Lydia. We'll move on now to the targeted therapies. And so I guess this was in a sense where it started with the EGFR mutations and the tyrosine kinase inhibitors. So we know that cancer cells develop due to genetic mutations which lead to uncontrolled cell growth. So certainly EGFR, MET and ALK mutations are involved in cell growth and survival, but we can now target these with kinase inhibitors. Increasing numbers of mutations are being discovered, and so increasing numbers of drugs are being developed which can target them. And so all patients with non-small cell lung cancer should now have their cancer tested for mutations. And this is one of the reasons why we now favour, for example, doing core biopsies of lung masses rather than fine needles, because one of the issues is we need to get enough cells often to test for these mutations. And I won't go into the drug side effects. I mean, the individual drugs have different side effects, but I suppose suffice to say that things like skin rashes and diarrhea are the common things. Thanks, Lydia. So in terms of how to use these drugs, I mean, it's just really a completely moving feast. And so newer drugs are being tested all the time, and they generally will show some small improvements in efficacy and some improvement in side effect profile, and then they become the standard of care. So osimertinib has now overtaken earlier therapies that were used for EGFR mutation positive cancers. Unfortunately, not all mutations have effective therapies yet, and you might have noticed that the KRAS mutation is actually the most prevalent oncogenic driver that we've identified up to this point, being present in about 30% of non-small cell lung cancers, but we don't yet have excellent drugs targeting this. We've got drugs targeting ALK and ROS1, and the newest therapies actually are what we call bispecific agents, and they can target a number of different mutations. And so, for example, amivantamab is quite a new drug, and it targets both EGFR and MET. And it's especially useful because when patients with EGFR mutant cancers start to fail their first-line osimertinib, it's usually with a MET amplification. So you could then change from osimertinib to amivantamab. You've got to spend a while learning how to say these names, actually. So a few take-home messages on the next slide about these drugs. What can we say? Well, major improvements in progression-free survival and overall survival have occurred as a result of these, but it's a very complex area, and there's an enormous amount of ongoing clinical work, and things are changing all the time. There's lots of TGA-approved drugs, but actually not all are PBS listed. There are potentials for patients to cycle through different treatments as first-line therapies fail. And in those who have driver mutations initially, repeat biopsy is certainly useful at relapse to best guide the next stage of therapy. Thanks, Lydia. So look, I think we're fast running out of time, and Claire, you can correct me if I'm wrong. So I will skip fairly promptly through a few other things, just to say that only recently there's some glimmer of improvement in the small cell lung cancer sphere. So durvalumab at the end of last year in a phase 3 trial was shown to lead to a longer progression-free survival that in patients who had finished their initial platinum-based chemotherapy. This year, tarlatamab after platinum-based chemotherapy was also shown to have a significant improvement in survival. So I think for a long time we felt a bit dismal about small cell lung cancer, which hasn't progressed as much as non-small cell, but there's certainly interest in that area. Thanks, Lydia. There are other things for you to be aware of, though, other important things in the cancer sphere. So this is a trial in the New England Journal this year, a phase 2 trial, and this was focused on cancer cachexia. And growth differentiation factor 15 is a stress-induced cytokine that's probably implicated in cancer-related cachexia. So this phase 2 trial gave patients who met the criteria for cancer cachexia various doses of a monoclonal antibody to block GDF15, and showed significant improvements in weight, anorexia, and physical activity compared with placebo. So that's a space to be aware of. Thanks, Lydia. The other thing that many of you might have already seen, again in the New England Journal earlier this year, is the fact that after 6 months of full dose apixaban, you can safely reduce to half dose or reduced dose apixaban in patients with cancer-associated VTE. There was no increase in non-fatal or non-fatal recurrent VTE, and there was a reduction in bleeding. And so that's of benefit. Thanks, Lydia. So I'd have to say the future is going to revolve around more trials to better refine our medical management of these patients, but it will also involve finding cancers at an earlier stage so that minimal resections or more targeted radiotherapy can be done. Potentially using intralesional therapies, so microwave or thermal ablation can potentially be used at the time of a needle diagnosis of cancer, so that one day, and this is possible now but needs to be tested further, but one day you might be able to have your biopsy and your treatment at the same session. There's likely to need to be refinements to the eligibility criteria over the course of some of the next 10 or 20 years as non-smoking cancers become more prevalent. And thanks, Lydia. And so to that extent, like Alice, I wanted to remind you all not to forget smoking cessation. I mean, there's excellent data that smoking cessation is important in cancer patients, even once they've been diagnosed. So the NSLT data showed that 7 years of smoking abstinence reduced lung cancer mortality by about 20%, the same as screening. And if you combine screening and smoking cessation, you double the benefit. And then there's been prospective data looking at newly diagnosed cancers, showing a survival benefit in those who quit across all cancer stages. And that has been supported by a systematic review of more than 10,000 patients. So it's really important to continue to focus on smoking cessation for patients to achieve their best survival. And just down the bottom of the screen on the left, you'll see a whole lot of vapes. And that's just there to remind me to say to you, well, they might taste great and they might look sexy, but we don't know what these things will be doing to people's lungs in 10 or 20 years' time. And so I personally am a big proponent of trying to discourage vaping. Lydia? That's it for me. Thank you.
Thank you so much, Liz and Alice. I think that both the presentations were really helpful and very informative, and definitely decreased a little bit of my anxiety about the new lung cancer screening program. So that was really helpful. There's just a few questions, admittedly mostly about the lung cancer screening program. So I might just go through a few of them. We've got a couple of minutes left, so we should be able to cover them all, I think. The first one is, which I also was thinking, is there any benefit, independent of economics, in doing low-dose CT chest assessment in someone who doesn't quite meet the criteria for lung cancer screening? So say, you know, only 15 years of smoking history, or not quite meeting the PAC year requirements. Do you think that there's benefit in doing those a scan sort of, I guess, outside the screening program itself?
Well, I guess the first thing to say is you can't get a Medicare low-dose CT for that purpose outside the screening program. But if we look at our screening program compared to other screening programs, ours is in its initial stages, and it's very tight criteria. In fact, tighter than other places in the world. And so if you look at Americans who've had this set up now for over 15 years, they've started to relax their recommendations. So I wouldn't say 10 to 15 pack year history. I wouldn't screen someone at that range, but there is evidence that once someone's over 20 pack years, there is potential benefit. And they've in other countries, they've also broadened their screening rate age as well. So like 80 to 50. So, you know, ours, it hasn't even started yet, but it's in its infancy. And hopefully with time, if we demonstrate its benefit, that we'll see restrictions relaxed. And also the other thing for me and Liz is we see a lot of young Southeast Asian women who have no lung cancer, who have no smoking history, but develop lung cancer. And so in the future, we would hope that our screening program can incorporate those women as well, who've never smoked, who've got no particular red flags. But at this point in time, I would definitely not be even thinking about scanning someone who's got less than a 20 pack year history.
Mm-hmm. The next question is about the specific order form for the low dose CT. Where do you get it from? And is it going to be integrated into our clinical software? Because that would make it much easier for GPs.
That would be common sense, wouldn't it? I know the National Cancer Screening Registry is integrated into the best practice and medical director, and there's another one. But I can't actually tell at this point, because if through that, because you've got to go into that to check if the patient's eligible and they haven't had other scans, it would make sense if they put the screening form in the radiology form in there, but I can't tell you yet because that register's not up and running. But separate to that, a lot of radiology practices are starting, albeit not in Sydney, but a lot of radiology practices are starting to put up their own version of the CT form as well, which covers all the same essentials. So I suspect with time, radiology practices who decide to participate will be sending GPs referral pads with the criteria as well.
Mm-hmm. And there are specific radiology practices that are doing these scans at the moment, is that right?
Well, no one is.
When the program starts, yeah, sorry.
No, yes, I know of a couple which are, but it hasn't been formalised. Once everyone declares whether they are or not, then we will include that in the Sydney Local Health District HealthPathways link. But at this time, it's not all published. So IMED, which is a big Sydney radiology practice, has put it up on there that they are. And Loomis Imaging is as well. But they're the only two to advertise it. They're going to agree to the project.
Mm-hmm. And so all of the scans inside the lung cancer screening program are bulk billed for the patient. Yes. So even if they say you have to come back in 3 months, that like every follow-up scan is free.
So perfect. Every patient, every single scan which the screening program recommends is covered by Medicare.
Mm-hmm.
There are situations where patients might leave the screening program. For example, if they have a cancer and then they come back into the screening program later on, they can continue on if they were young when they were identified. Or if someone has a chest infection and it's not appropriate for them at that point in time, they can come back in later. So you can leave and come back to the program if you still meet the 50 to 70 age year bracket.
Mm-hmm.
As soon as you're 71 for the program at the moment, you're no longer eligible for the National Lung Cancer Screening Program Medicare scans.
Mm-hmm. And the screening program will remind patients when their follow-up's due, if it's like a shorter interval than 2 years. So I know you said they'll remind every 2 years, but they don't remind unless the first scan is normal. Is that right?
They don't remind unless it's normal. Exactly.
Okay. So then it's up to the GP to put reminders in about when the next scans are due.
Yeah.
Okay. So do you know if that will, because at the moment, what happens is when our software is integrated into the National Cancer Screening Register, it gives us reminders to say, you know, this person's cervical screening is overdue, or this person's bowel cancer screening is overdue. Do you know if that's going to happen if it's inside the 2-year scan interval?
I would hope they've planned that into
Yeah.
it, but I don't know for sure because I haven't had access to that because I don't have those screening programs. But you would think if they're integrating it into the register, that it should do that. The tricky patients are going to be those patients who choose not to have their reports put into the register or don't want to be part of the register full stop, because then all the onus on follow-up will fall with the referring GP. Yeah.
And then my last question is, for patients who have a recommendation to refer to a respiratory physician, are there specific places we should be referring, or is any respiratory physician, or should we refer to the nodule clinic at Concord if you're in the Sydney LHD? Does it matter?
The recommendation is to refer to a respiratory physician who's associated with a lung nodule MDT / lung cancer. Not everyone's set up nodule MDTs, but as you can imagine, our cancer MDT is already overrun with patients. We decided that we needed to set up a separate nodule MDT because the management is different. And then if we do identify cancer, then they'll feed into the lung cancer MDT.
Perfect.
But you know, I think we have physicians who work at Concord Hospital who attend our MDTs, but also people who work in private practice who present their patients at our MDT. So we encourage a collaborative and supportive environment for those in private practice. So in reality, I think my advice for GP is decide on what your referral practices want to be. We're more than happy to have them in our lung nodule clinics, but we will not know until how many we get, where demand lies. and like we're already running 2 a week. And separate to that, private respiratory physicians are well skilled and trained to manage these patients, and if they have an association with an MDT, would also look after your patients well.
Great, thanks so much. There's a few questions just saying, will the participants get slides, which they will after, so anyone who's attended will get a copy of the slides. And there was a question just at the beginning that I just wanted to address because I saw that Tammy answered it, but basically someone asked, can nurses get access to HealthPathways? Yes, any health professional can have access to HealthPathways, including medical students, registrars, anyone. So if you are having problems registering, just send an email to the HealthPathways team and they'll help you out. So I tell all of my medical students to register because I think it's excellent, but I don't know how many do, but we'll, you know. So I think we are right at time. So I just wanted to say thank you both again. It was really informative and interesting. And I'm sure it's provided a lot of information for everyone who's attended tonight. I'll pass over to you, Lydia, just to wrap up.
Thank you, Claire. And thank you once again to our speakers and facilitators. And thank you everyone for attending.